And let's we get.
How does, can everyone, I also hear a little feedback. Oh, that's just, so if you, perfect, that sounds good. I think if you just mute that volume. Okay, thanks for bearing with me through all the technical difficulties there. I just turned that off altogether. All right, well, lucky for me, I was recording all of that, so I'll do some editing throughout this presentation. But to back up really quickly, I just wanted to go through some of our general housekeeping items. Same as every webinar, we are going to be keeping you all on mute throughout the presentation. However, you all have found the chat box and have been already using it very well, so please continue to do so. And if any questions or other comments such as the audio come up, please feel free to use that throughout the presentation. At the end, we will have time for question and answer session. And so you can either jot down the questions in the chat box throughout the presentation and we can get to it at the end, or you can save it and just type it in at the very end. And Dr. Bloom will be happy to go through those questions as time permits. At the end, we will, or a little bit after the presentation, I'll be sending out a link to the recording of this webinar, as well as the slides, a PDF version of the slides. So be on the lookout for that email. And additionally, if you are interested in claiming SHRM credits, please view the email, which will have further instructions on how you can claim your SHRM credit for today's webinar. So, without further ado, I will introduce our speaker today. Dr. Bloom is an internist and addiction medicine physician at Denver Health, where he manages the HIV primary care clinic. He also provides HIV and transgender care in the Denver City and County jails and treats addiction disorders in Denver Health's Behavioral Health Services Department. He is an institutional quality officer for pain and opioid management and currently oversees the expansion of medication-assisted treatment in the Denver Health primary clinics. He is the co-chair of the Provider Education Work Group at the Colorado Consortium for Prescription Drug Abuse Prevention. And I will let him take it from here. I will let you share your slides.
Great. Thanks, Kayleen. I think I want to make sure everybody can still hear me because I think we're using your microphone now, if that's okay. And I'm going to
do see some yeses.
Hopefully you all can, and hopefully it's clear. If you cannot, please let us know. Thank you so much for having me. I want to thank the Center for Health, Work, and Environment for hosting me here in their offices. And I want to preface my talk just simply by at least saying, as a primary care physician, this is going to have a little bit of a primary care bend. I am not a medical review officer. I am not also someone who really has to manage opioids in the workplace as you all do. So my perspective will be a little bit different. Please feel free to ask questions or add your comments or concerns of any of the information you hear in this talk today. I have no disclosures. I have no conflicts of interest. I unfortunately receive no money from drug companies or others to hawk anything. Here's what we're going to go through today. We're going to review the background and scope of the epidemic, opioid indications, if they even work for pain, the impacts on workplace function, and then we're going to finish with helping you all recognize the signs and symptoms of an impaired employee and how to refer an individual for definitive treatment. And Kaylee, I'm hoping you will tell me when we're at 5 or 10 minutes and give me the high sign. Thank you so much. When would you like me to stop? Just
I'd say let's give about 10 minutes at the end.
Okay, so. Fair enough. So we have about 40 minutes of this. So how did we get here? let's go through this. Many of you probably know the story, but I think it's worth recapitulating. This has its roots in the 1980s when there were first some articles published questioning the conventional wisdom of avoiding opioids at all costs, or so-called opiophobia. There were some case series that were published that demonstrated there really wasn't a lot of evidence of opioid abuse among patients chronically on opioids for pain, and advocates really felt like we should be using more opioids to alleviate suffering. Then in 1983, the long-acting version of morphine was released. In the 1990s, after the release of a medicine, particularly after the release of a medicine called OxyContin, which is a long-acting version of oxycodone made by Purdue Pharma, we were unwittingly being marketed to as primary care physicians and pain physicians. Through the support of the pharmaceutical industry, they were harnessing thought leaders and people who garnered a lot of respect in the industry to give us talks on how to use opioids more effectively and more frequently to treat chronic pain. And the gospel then was opioids are safe and they're effective and they are easy to take people off of when the time comes. And we actually now know the kind of the opposite of all three of those statements are true. So also, as OxyContin was marketed as being unlikely to cause addiction because it has a long half-life, and that is also patently false. So in the 2000s, with the spread of opioid prescriptions, we really saw these pill mills develop, but even outside of pill mills, simply primary care providers readily embraced the ability to prescribe a medicine that we thought was effective for pain. We thought we were doing good by prescribing it. And so we saw a concomitant increase in overdose death rates. At the same time, black tar heroin was being spread into small markets and out of simply being a coastal phenomenon into every small town and small city across the United States. And this is the pizza delivery method, so-called because you could call a pager number and a drug dealer who didn't necessarily have to be someone who was using drugs himself would literally meet you on a street corner within 5 or 10 minutes and deliver you a bag of heroin. This movement targeted municipalities with high rates of opioid dependence, and they would even stand outside of methadone clinics in order to advertise and to give free samples to people to get them hooked again. So where are we now? Well, this is actually old data now. We were at 72,000 overdose drug deaths last year nationally, in 2017, I should say, which is higher than peak car crash deaths, which is higher than peak HIV deaths and gun deaths. And officially, according to the National Safety Council, opioid overdose deaths have replaced car crashes as even the highest rate of death. And here's what we've seen with regard to opioids, that we peaked with prescription opioids somewhere around 2010, and we actually have seen a reduction year after year of around 8% in prescribing of opioid therapy since 2011. And so the overdose death rates from commonly prescribed opioids has flattened, but synthetic opioids, particularly the fentanyl you read about in the papers, and heroin have really picked up the slack and have been particularly deadly lately. So the upshot is that the overall overdose death numbers and rates have been increasing. What about with prescription opioids? Because as I mentioned, we've been prescribing fewer and fewer year after year, and physicians are getting better about that. And we're seeing the death rates stabilize from that aspect. How often do people misuse prescribed opioids? How often do they divert opioids? We really don't have a good answer to that question. We really don't know. But we do know that we're still prescribing opioids at roughly 300% of what we were in the late 90s. We know that some portion of those drugs gets out of the hands of the patients we're prescribing them to and into the hands of others. And the problem is it gets in the hands of people who are at high risk for overdose death. So it turns out that 4 out of 5 heroin users began with prescription opioids, and the majority of those people obtained them free from a friend or relative. So even though we are prescribing more responsibly and we're prescribing fewer opioids, we know that some portion of these drugs are still contributing to the opioid epidemic, and that the medications we are putting out there are leading to people then turning to drugs like fentanyl and heroin. So we are still contributing to the epidemic even as we improve our practices. So what do you all need to know about opioids? Here's a few questions I thought might be good to answer for this webinar. Do opioids even work for chronic pain? What are the risks in the workplace? And then how can I tell if an employee is intoxicated? How can I tell if an employee has addiction, and what can I do about it? So I'm going to try to go through these questions one by one. Do opioids work for chronic pain? This is a controversial topic. There's modest benefit in short-term studies, longest being about 16 weeks, that opioids are effective for osteoarthritis for neuropathic pain. There have been some recent reviews that showed that opioids really are not superior to anti-inflammatories and other drugs for chronic pain. The papers have reported this as saying that opioids are ineffective for chronic pain. That's not true. They are effective. They're simply not more effective than other less risky, commonly available treatments. We have also had some systematic reviews that have shown that chronic low back pain in particularly does not really respond terribly well to opioids, that you see non-significant reductions in pain, less than 1 out of 10 on a 0 to 10 scale of pain. And opioids have never been shown in any study to improve functional status or quality of life. So again, there may be some benefit for pain in some patients, and some people might do quite well because case studies have shown that there's some long-term improvement in stable dosing in certain highly selected patients. But overall, the sum of evidence is that these medications are only modestly effective and don't have any impact on functional status or quality of life. Additionally, there are some indications where we really tried hard not to use opioids, specifically headache, fibromyalgia, or any chronic widespread pain, chronic abdominal or pelvic pain, and then nondescript low back pain, for example, from a failed back surgery. These are diagnoses. We really try to avoid them now, although we know that we have a lot of legacy patients who were started on opioids in past decades, who are on them for these or even worse indications and are just maintained on them because it's very, very difficult to wean people off of opioids. Opioid use controversies. The American Pain Society, the American Association of Pain Management in 2009, or again 10 years ago, before the high point of the epidemic, said long-term opioid therapy can be effective for carefully selected and monitored patients with chronic pain. Chronic opioid therapy, though, is associated with depression and anxiety. It's associated with job instability and low satisfaction, and substance use disorders and patients receiving disability. So the evidence overall is a very mixed bag. And with the worsening of the opioid epidemic, I would say those of us who do this work would say, for the vast majority of patients, and except in very exceptional cases, opioids really are not indicated for the routine treatment of chronic pain conditions. How about opioids in the workplace? We know this is a common problem, and low back pain is the #1 reason why most people use chronic opioids. It was over 50% of chronic opioid users had some level of back pain in one study. Low back pain is incredibly common. It's almost half the population of people aged 40 to 65 and is the major cause of lost work time. Opioids do not facilitate return to work, nor do they improve function, as previously mentioned. Additionally, the duration of opioid therapy, particularly greater than 7 days, is associated with increased medical costs and lost work time. So we have learned in recent years that the duration that opioids are prescribed for really dictates whether or not patients are likely to be continued on opioids chronically. And there really does appear to be a major inflection point at 7 days. If you really look at the evidence, it even goes back to 3 days. So if you're prescribing more than 3 to 5 days of medicines for acute pain, you're really increasing the risk that a patient is likely to wind up on chronic opioid therapy longer term. So as physicians, we're trying to educate ourselves to say, look, use opioids at the lowest doses possible for the shortest durations possible. What about an opioids and workers' compensation? How do opioids impact things? So clearly, opioids are associated with higher occupational claim costs. Compared with individuals who are not on any opioids, the odds ratio of having a claim over 100,000 is considerably higher for people on opioids. You are almost 4.5 times more likely to have a claim of over $100,000 if you were prescribed short-acting opioids, and you were 8.5 times more likely to have a claim over $100,000 if you were prescribed long-acting opioids. Now, it's important to point out that this is not causal. It doesn't mean that patients who were prescribed opioids that this caused them to have higher occupational claim costs. And it could be simply associative. In other words, that people who have more severe injuries and more severe disability are precisely the ones who wind up getting prescribed opioids, especially long-acting opioids. And so this may be associative, this may be completely appropriate, but clearly there is an association between these medications and higher claim costs. Additionally, and what might be a little more concerning, is people obtaining prescriptions from multiple providers. And this has been now well recognized in the medical community as something of concern, not just in workers' compensation patients, but in all patients. That if you have a patient who is going around to multiple providers, even if it's appropriate, even if it's a specialist and a primary care doctor and an ER doctor, someone who's obtaining prescriptions from multiple providers is much more likely to be on a higher morphine equivalent dose, and is also much higher to be at, has much higher risk of opioid overdose death. So I know you often don't have the ability to know if patients are prescribed certain medicines, but if any of you have access to pharmacy benefit managers, you might be able to get at some of this information. And those who are using multiple providers, especially those who are, quote, doctor shopping, are at the highest risk of having these catastrophic complications. How do opioids impact function in the workplace? Is this something we need to be concerned about? Opioids, particularly when they're initiated or when the dose is increased, are associated with psychomotor slowing. They're also associated with drowsiness and fatigue. These are known consequences of using opioids, and to be expected, again, at the onset of therapy and with any dose change. The degree of psychomotor slowing and the degree of drowsiness and fatigue is actually quite similar to just basic shift work. That if you compare psychomotor tasks in patients on opioid therapy, they compare very similar to someone who's working a swing or an overnight shift. Opioids are also associated with ladder falls. So patients on, or individuals on chronic opioids are more likely to have a fall from a ladder. And they're associated with increased fracture risk. The fascinating thing about this is that is independent of whether they've been on it long-term or not. Even with a single prescription of opioids, patients, and sorry, I keep using the word patients because, of course, they're patients to me, they're employees to you, but individuals are at increased fracture risk. Opioids are thought to have some impact on bone metabolism, and that in the long term, they may cause increased likelihood of osteoporosis and fractures, but probably the increased fracture risk seen with a single prescription is more related to this balance, these balance issues you can see with onset of opioids. For opioids and driving, the evidence is conflicting. Early reviews showed that there was really no association, even with consistent evidence, and this is a review from 2003, no association at all between patients using chronic opioid therapy and any issues with driving. And again, these are people, it's important to point out, who are on stable chronic doses of opioids. However, more recent reviews have shown an association between opioids, especially with other central nervous system depressant drugs like benzodiazepines. And benzodiazepines are medicines like Valium, perhaps you've heard of the brand name Valium or diazepam, or Klonopin or Xanax or other brand names. Opioids plus benzodiazepines is a particularly dangerous combination, and sleep deprivation. And it actually looks like chronic pain alone can also impair driving. So patients with moderate or severe pain, particularly severe pain in one study, was associated with driving impairment equivalent to having a blood alcohol level of 0.08. So it's important to recognize that there's a lot of confounding factors in these studies that are trying to look at opioids and driving. And it's impossible to make a blanket statement that says, yep, you put someone on opioids and they're at increased risk for an accident. And you just can't say that. Additionally, chronic pain patients are more likely to be on multiple psychoactive medications. So there may be several drugs that they're taking that can have a cumulative effect on their psychomotor function in their driving. So a very measured conclusion reached by this study, this review in 2012, was that driving on opioids is likely safe if, and this is a big if, there are minimal additional risks. And that means no co-prescriptions of other psychoactive medicines, no use of other central nervous system depressants like alcohol or illicit drugs, no concomitant severe pain, that hopefully the pain is reasonably well controlled, that there isn't a sleep disorder or daytime somnolence, or swing shift or overnight work, because all of those, again, are associated with driving impairment themselves. And then other psychiatric disease, which is associated, of course, with being on more centrally acting medicines, and also with more likelihood, a greater likelihood of opioid misuse. So sorry, I realize that's clear as mud, but I think we can be somewhat reassured that if people are on chronic, stable doses of opioids, if they're working in the daytime and they're not on other medicines and their pain is well controlled, that those people can be considered reasonably safe to drive. The American College of Occupational and Environmental Medicine has said you should monitor carefully for adverse effects from opioids, and still do not use opioids in safety-sensitive jobs, particularly those operating heavy machinery, heavy equipment, and use extreme caution, I would add extreme caution, with benzodiazepines and other CNS depressant medicines. In fact, that's the big no-no now in medicine, is using opioids and benzodiazepines together. In one study from North Carolina, the combination of those two drugs together was associated with a 10 times increased risk of overdose death. How do you in the workplace recognize impairment and addiction? Tough question. First of all, there can be some obvious signs and not so obvious signs. Mood swings, people who are acting somewhat erratic, personality changes, unexplained tardiness and work absences, frequent illness or physical complaints, excuses, underperformance, difficulty with authority, or poorly explained errors, accidents, and injuries. Clearly, some of these are symptoms you might simply see with a bad employee, or someone who has a major mental health issue, such as depression or anxiety, or who is going through a major life issue like a divorce or some other upheaval. So they're not necessarily all specific to impairment from drugs and alcohol, but these certainly are the symptoms to look out for, and should, if you do observe these, should trigger an intervention with the employee. Other signs: memory loss, forgetting instructions, an individual who refuses drug testing, someone who's taking a lot more time or taking greater effort to complete a task, is not meeting deadlines, is having issues with relationships at work, and then maybe when things are really off the rails, wearing long sleeves when inappropriate work to cover up track marks for someone who's using injection drugs. At work, you may encounter people who are actively intoxicated. And I want to just mention opioid intoxication. People become relaxed. They might have slowed speech. They might be sleepy looking. They might even be nodding off. These are people who I think they might claim that they're simply tired from poor sleep, but if you see pinpoint pupils, you should suspect that someone might be under the influence of opioids. I've also put the signs and symptoms, or the signs of overdose here, because increasingly we are seeing workplaces and individuals carry the opioid rescue drug naloxone or Narcan. This is a reversal agent that can reverse an overdose. And many states, including Colorado, have legislation passed that says it's illegal for people to carry Narcan around, because if, God forbid, you come upon someone who is actually in the midst of an opioid overdose, that you can give them Narcan and potentially save their lives. I don't think this is a requirement, but anybody listening to this call, I would say having a Narcan in your possession is a really good thing, and will soon become part of basic life support, similar to the way AEDs are everywhere. So what else can you all do? you can recognize, in addition to recognize intoxication or recognize the signs of worsening performance that might suggest a use disorder, you can also look for the signs and symptoms of opioid use disorder, and we're going to talk about what those criteria are in a few minutes. But please refer impaired employees for treatment and consider creating a drug-free workplace policy if you have not done so already. Also, about 70% of companies have employee assistance programs. These have demonstrated substantial return on investment, between $1.50 to $13 per $1 spent. They are inevitably underutilized because employees fear repercussions. However, if they're there, some substantial minority of people will take advantage of them, and they do represent, I think, the best hope for getting someone to engage in treatment and maybe to admit that there's a problem. In a National Safety Council poll of HR officers, 70% reported that they were seeing the effects of opioid use in their work environment with absenteeism, safety incidents, and decreased productivity. Only a small minority felt prepared to deal with this. And when it came to urine testing strategies, almost half of these companies and HR officers reported that they did not test all employees and that they don't test for synthetic opioids. And the most commonly prescribed opioids are these synthetic and semi-synthetic opioids like oxycodone and hydrocodone. They're not routinely picked up on standard drug tests. Additionally, fentanyl, which people might be using even in tablet form and really has spread from the coast now, is absolutely not picked up. You have to send a specific test for that. If you're curious about the cost of substance use to your organization, you can go on the National Safety Council's website, and they have a substance use cost calculator that just takes into consideration what part of the country you are in and the number of employees you have and some other factors to come up with the cost for you. A little bit more about urine toxicology testing. SAMHSA, the Substance Abuse and Mental Health Services Administration, has a checklist. If you're going to implement this in the work environment, you need to identify your pertinent federal and local laws. You need to consult your union officials. Make sure you're protecting employee confidentiality. Develop a clear and fair policy. Notify your employees before you implement it. Contract with the medical review officer, and make sure you apply the policy equally to all employees, including leadership. Here's some sample verbiage that I'm going to read for a policy, and I apologize for those who already have these in place, but if any of you don't. Employees may not possess, sell, distribute, or use alcohol, illicit drugs, or any other intoxicants. Prescription drugs may be taken only if done so according to a medical professional's prescription. Over-the-counter medications at standard recommended doses only. Employees are responsible for consulting medical professionals, such as a physician or pharmacist, to determine whether any medications, prescribed or over-the-counter, could impact the safe performance of his or her job. It is the responsibility of the employee to use appropriate personnel procedures, such as sick leave or the notification of the supervisor, to prevent an unsafe workplace environment or practices. Violation of this policy may result in disciplinary action. So that's a short sample policy. Similar verbiage can be used to implement in your organizations if you've not done so already. So with the remaining time, I want to get on my soapbox for a minute as a physician, as an addictionologist, and talk to you about addiction and the stigma of addiction, and also the criteria of addiction disorders, or use disorders as they are now called. So it's important that you all understand that addiction is a chronic relapsing disease. We call it a disease because it has a strong genetic component that results in permanent changes in brain structure and function. In fact, you can look at functional MRIs of people with a history of opioid use disorder, people who have a history of opioid use disorder and are currently using, those who are previously used and are on methadone, and even those who are in long-term recovery. And there are still conformational changes to the brain in the way the limbic, the reward system of the brain, lights up. Even in those who are in long-standing recovery, your brain never goes back to normal once you have a use disorder. And that's scary and sad, but it also speaks to why this is a chronic disease and not something that people just get over and fix. The hallmark of addiction is loss of control. Your brain is literally hijacked to use drugs and to prevent withdrawal symptoms. Addiction is also very difficult to treat. In medicine, we are trying to educate our fellow providers that simply taking someone who has an opioid use disorder off their opioid therapy, whether it's used for a legitimate purpose or not, that simply stopping the opioids does not fix the problem. In fact, detoxifying someone with an opioid use disorder is actually the opposite of treatment, because detoxification is associated with very high rates of relapse. And so, in fact, even if someone goes to, say, residential treatment, gets into sobriety, and comes out of treatment, they will come out with no tolerance. And if they go back to using their drug of choice, they're actually at higher risk of opioid overdose death. That's actually the highest point in time of risk for opioid overdose death. So there's increasing recognition that detoxification is really not the answer. How does addiction hijack the brain? Well, when you first use a drug, this curve is looking at dopamine levels. Dopamine is your major reward hormone in your brain. And you have a basal level, that's that line going across. When you use a drug, you get a big shot of dopamine in your mesolimbic system, in your reward pathway in your brain, and you feel really good, and you feel euphoric. And then after you use, you have a little deficit of dopamine, but then you go back up to normal. What happens over time, though, is your body, your brain, downregulates dopamine receptor activity so that you get less and less of an effect or release less and less dopamine, less and less of that pleasure hormone as time goes on with repeated use of the drug. However, even though you're getting less and less high or euphoric from the drug, after use, you're getting lower and lower. Your dopamine levels are actually going lower and lower because your brain is adjusting to this. This is called allostasis. So that pretty soon your new allostatic level of dopamine is well below normal, and you feel awful when you're not using your drug. And then you may be using your drug simply to feel well and to feel normal again. And this curve was developed for alcohol, but you could substitute any habit-forming substance in this, especially short-acting opioids. They fit perfectly and are superimposable over this curve.
So I'm curious, with this graph, does it relate back to what you were saying previously? Even after you've been in recovery and all of that, does this still maintain at those lower levels after a person has gone through treatment?
That's a great question. With time, people's dopamine levels return and approach normal. At baseline, do they ever really get all the way back up to normal? That's kind of controversial. What we can certainly say is they may get back to normal, but if you give them the drug again, they still don't get the same peaks that they got, say, the first time they used the drug. And people will frequently say that. You know, I got this incredible intense high the first time I used heroin or methamphetamine, and I've been chasing that high ever since. So here's the cycle of addiction. And I know this is getting in the weeds a little bit for you non-medical people, but bear with me and it's not scary. We're going to talk in layman's terms here. When people binge or get intoxicated, that is harnessing parts of the brain that, again, is called the mesolimbic system. This is the limbic system is the reward pathway in your brain. You are stimulating that reward pathway in your brain. But as you come down from the use of the drug and you start to enter withdrawal, which includes very substantial physical effects, those dopamine levels, like I said, go very, very low. And in fact, you activate a part of your brain called the extended amygdala, which has areas called the locus coeruleus and other areas that are major negative emotion areas of the brain. Your amygdala, when it's activated, that's what's going to make you feel dysphoric, make you feel anxious, nervous, feel like lashing out, angry, irritable. That's all located in your amygdala. And so when you're in withdrawal, you are your amygdala is going crazy, and you literally feel awful. You feel like you want to lash out at someone. You're not really yourself. When you move to the third stage in the cycle, preoccupation anticipation, you start to stimulate your prefrontal cortex. Your prefrontal cortex is your major executive center of your brain. This is the part of your brain, this is the air traffic control center of your brain, the part that lets you get stuff done, the part that lets you make lists and organize and do things like that. When you start to get some triggers and feel, oh, I'm going to use again, your prefrontal cortex, your air traffic control center, is completely hijacked in the service of acquiring and using the drug. So that means I'm going to steal from my grandmother or my friend, or I'm going to ask him for money, and I'm going to get the drug, and then I'm going to go to this neighborhood, and I'm going to get the drug, and then I'm going to go to my place where I like to use, and I'm going to use the drug, and I'm going to enjoy it. So the planning is simply remarkable. And that is, again, the complete hijack of your executive function. You're not going to think about work. You're not going to think about that deadline that's coming up. You're only going to think about what it's going to take to get the drug. And interestingly, in that preoccupation phase, your body is starting to send small triggers of dopamine to your mesolimbic system. So you're getting little pleasurable effects in anticipation of use. And this is why it's so hard to maintain sobriety. The alcoholic who walks by his or her favorite bar that is associated with drinking, he or she is already getting those little stimulations of dopamine. And that creates this incredible drive and the craving to use. And pretty much after that, they're locked in. They're not going to stay in recovery. And that's why people, when they're exposed to the same triggers where they're used to using, they have no chance of success. So that's the cycle of addiction. Luckily, opioid addiction only occurs in a minority of patients on chronic opioid therapy, about 2 to 5% in kind of people at average risk. But if you multiply that by the number of prescriptions out there, that's still a large number of people. That's a large number of employees. And as we said before, it's a chronic disease that needs to be treated. And weaning off opioids is not addiction treatment. You saw that cycle. If someone is in sobriety and they come out of that 30 days of residential treatment with their shaky recovery, and then they go and happen to run into their friend or their, God forbid, their drug dealer, they have zero chance of staying in recovery. So opioid use disorder has a bunch of criteria. I'm going to show them to you, but don't get scared because we're going to talk about really how you can identify opioid use disorder yourselves. These are the criteria. Opioids are taken in larger amounts or over a longer period of time than intended. Persistent desire or unsuccessful efforts to cut down or control. Someone spending a lot of time is spent in activities necessary to obtain, use, or recover from the effects. Craving. Failure to fulfill major role obligations at work, school, or home. Recurrent social or interpersonal problems caused or exacerbated by the drug. Giving up other activities because of use. Use in situations where physically hazardous. Continued use despite persistent or recurrent physical or psychological problems likely to have been caused or made worse by the drug, and then tolerance and withdrawal. That's a lot, and tolerance and withdrawal can't be applied if the meds are prescribed. That's a lot. Those are a lot of things to think about, but really you can remember that there's actually one other C I didn't put in here. When people are using compulsively, when they have lost control, when they're not controlling the drug is controlling them. And when there's been consequences to their use, that's addiction. So we all see this. We all probably know people in our own lives or unfortunately in our own families who've experienced this. They've lost control of the drugs. There have been consequences of their use. Maybe they have some craving and they have some physical dependence. They are checking all the boxes of addiction. This does not take a medical professional necessarily to diagnose. We all know severe addiction. We've all seen severe addiction. If you see severe addiction, medication-assisted treatment is the treatment of choice. Detoxification doesn't work. When you look at people who are detoxified from opioids versus people who are maintained on treatment, the tapered patients almost always relapse. So who are these nice people? Why are they important? Vincent Dole was a physician and Marie Neiswander was a psychiatrist. He was the guy who first said, maybe addiction isn't a personal or moral failing. Maybe this is not just an issue of willpower. Maybe it's a metabolic disease of the brain. And maybe we can stabilize people by giving them a drug that will allow them to function and go back to work. And then people said, well, you're just giving them a crutch. And to that he said, look, if you lose your leg, it'd be great if you could regenerate your leg, but we can't regenerate legs. What's wrong with giving people crutches so they can get around and ambulate reasonably normally? That was over 50 years ago. We are still fighting that same stigma today, despite the fact that we know that opioid maintenance reduces illicit drug use, euphoria, decreases complications related to opioid use like HIV and Hep C infections, skin and soft tissue infections, criminal behavior, and you see extinction of craving, of the priming and repeated pattern of binge use and withdrawal. That cycle, people can get off the cycle when you start medications like methadone and buprenorphine, these long-acting opioids. And just the bottom line is that it saved lives. 25 fewer deaths per 1,000 person years of people who go on to medication-assisted treatment. That's it. You just die less when you go on medication-assisted treatment. Hard stop. It's evidence-based. The time has come to put the stigma away. Medications that are used are methadone, buprenorphine, or the medicine Vivitrol, which is naltrexone, a long-acting opioid blocker, which can be given as a monthly shot. It's just hard to get people on that if they're in the throes of opioid addiction. But we have options. There's a massive treatment gap across the country. There are 48 out of 50 states with more opioid use disorder patients than places to put them. There's a gap of over 1 million patients. And in my home state of Colorado here, we have an estimated gap of around 30,000 people, even in a smaller state. Primary care is going to fill that gap. We are hard at work training more primary care providers to provide this service. And you can find primary care providers in your communities, in your states, who can prescribe buprenorphine, who can get people on this and allow them to return to function. So in summary, the opioid epidemic will continue for years to come. It's probably going to be, it took us 20 to 30 years to get into this mess. It's going to be another 10 to 15 years before we really have a good handle on it, though most things are moving in the right directions, just not the heroin use and the fentanyl use right now. Your employees may have legitimate opioid use indications, and that those rather rare patients on stable doses who are also on limited other psychoactive substances and who are not working shifts or overnight shifts or swing shifts likely have a low risk for psychomotor impairment. However, they still should not be put into high physical risk job positions. As HR officers and other employers, it is incumbent on you to recognize the signs and symptoms of an impaired employee, not only for your own safety and for work performance issues, but also because intervening in an employee's life could actually save their lives if they have opioid use disorder or other use disorders. Evidence-based opioid use disorder treatment really simply means medication-assisted treatment. Detoxification, residential treatment with patients, and even in sobriety, even the best meeting programs, even 90-day programs, that is not considered evidence-based treatment any longer. And increasingly, even these residential programs are recognizing that, hey, this is a good opportunity to get people on medication-assisted treatment, so we continue their or maximize their likelihood of success after they leave us. There are 3 approved medications for medication-assisted treatment, but methadone has to be prescribed in specific methadone clinics. Those are very limited in location and in access. Buprenorphine and naltrexone can be prescribed in primary care offices, and so if providers get trained, they are able to offer this service, and more across the country are getting this training. And I just want to put in a plug for the fact that getting the recognition of addiction as a chronic relapsing disease and not a personal or moral failing can make you more patient with employees who actually have this terrible disease, and at least give them the benefit of the doubt or give them the opportunity to get into treatment. And if they can successfully engage in treatment, allow them hopefully to continue to be employed. Obviously, if people do not want treatment or are not ready to engage in treatment, that's a different issue. And while we want to support those people and maybe make sure that they don't overdose and die, that is, we want people to engage in treatment in order to continue safe employment. I'm going to end there and open up to questions and discussions. And I'll stop the screen share.
Sure. Thank you. That was really wonderful. I have a couple questions written down, but I'm going to also open it up. If any of you have your questions and are ready to type them in, please feel free to do so. I have the chat box open, and we will be on the lookout for anything coming your way or from each of you. So in the meantime, just going to put that up. I'll leave that there. We'll get to that part after. But one of my questions was if you are aware if there are certain industries that are more affected by opioid use and abuse, like if you see these trends in construction or a different type of industry more regularly?
So men are more likely to have opioid use disorder than women. I can't quote you data, but construction certainly has high rates. Oil and gas tends to have very high rates. Any industry where people are often injured or have chronic pain, doing a lot of heavy lifting, especially that's a male-dominated industry, is going to be at higher risk of having opioid use disorder patients on opioids.
Okay, thank you. I enjoyed the drug-free workplace policy that you put up on the slide, and I was curious where you pulled that from, or if you had a recommendation that I could include, a link to maybe SAMHSA or somewhere like that.
I believe there are some links on the SAMHSA website. Additional, the National Safety Council is probably a good place to start for that. I essentially took that policy and even dumbed it down a little bit more and shortened it from a National Safety Council publication. Don Teeter is the physician who I believe wrote that, did a wonderful job with that document.
Thank you. Anne, I saw that Annie, apologize, I saw you raised your hand, and I tried to unmute you. I don't know if on your own computer or phone you need to unmute, but if not, feel free to type in your question. Maybe while Annie is figuring out the microphone, you also mentioned pharmacy benefit managers, and I'm unfamiliar with that, so I was curious if you wanted to touch a tiny bit more on who those people are, how to access them.
So pharmacy, that's really more companies. These are,
okay.
If in larger organizations, you may be buying health insurance from an insurer that uses a PBM, a pharmacy benefit manager, where this third party can run reports. Okay. They're not going to give you information about individuals, but they might give you overall reports about medication usage or how much employees are, are buying of certain classes of drugs. There may be other ways to sort of get at trends in your state or your municipality, either through the prescription drug monitoring program or other publications from your local health board that tell you that information. Some PBMs, some of these prescription drug benefit managers will send push notifications to physicians saying, hey, your patient so-and-so we just want to let you know, has filled prescriptions from 3 different providers. Okay. Did you know that? And so sometimes those are really nice. I mean, I sometimes get those, and it's great. I never mind getting those, because even though I might know all about it and it might be totally appropriate, just someone else looking at that, especially if the physician is not checking the state's prescription drug monitoring program, can help tip the provider off to someone who's developing use disorder or is at high risk.
Absolutely.
Annie appears still to be muted.
Yeah, I tried to click on mute a few times for you, Annie, and it doesn't seem to be working on my end. So if you do have a question, it might be easiest to chat that in the chat box. And lastly, I was just thinking, relating back to here. Oh,
she wrote, so sorry, that was a mistake. So no question.
No worries at all. So knowing here at HealthLinks, we work with employers to really boost their programs, policies, practices around anything total worker health. And I caught that you said low back pain is the #1 use or way people are prescribed opioids. So then my brain started going, well, how can we combat low back pain?
That's a great question. So in last year, the American College of Physicians put out a statement paper. It was published in Annals of Internal Medicine, basically saying that for acute, subacute, and even chronic low back pain, medications are not first line. Okay. That we have to do a much better job of re-educating all of our employees, all of our patients, to say, look, low back pain drugs are not the answer, even the non-habit forming drugs, even the anti-inflammatories. Sure, you can take them if you have acute pain. The name of the game is moving again. It's getting moving. Even if you have really substantial, bony disease or disc disease, it's about functionality and keeping functional. So physical therapy should be first line for low back pain. If you, as an employer, can offer things like yoga pool therapy, anything like that, anything that's related to moving, Tai Chi, those are all associated with better outcomes with low back pain. So I think there's tons and tons of good stuff on the internet around educating patients about that, about what is the treatment of choice. Acupuncture is another one that has been shown to have efficacy in low back pain. And so I think just making sure it's clear that it's really about not using drugs, but about getting moving. And then putting it back on the individuals as well. Too often it's about, hey, what are you guys going to do to fix my back pain? That's not the way to think of any chronic pain, and especially back pain. It's, hey, what are you going to do to support yourself? How are you going to get yourself moving so you can meet your functional goals again? Because look, most of the universe experiences intermittent low back pain. It's about half of all people. So it's your back, you're the one living with this. What can you do? Oh, do hot showers make things better? Does a little bit of stretching make things better? Great. Oh, you're not moving at all? Let's get you moving again. Let's get some goals around activity. Maybe you can go to a local, the local gym or yoga studio and start with some basics.
Definitely. And you touched on things, the way that employers can support those people doing their own individual tactics, whether it's yoga. I wrote down things like stretching or walking meetings. I'm even curious, if there's studies out there that say just the ability of having the sit, stand, desk, so being able to move from one position to the next. I don't know the answer to that, but it sounds like there's some strategies employers could really take to help support those individuals.
Certainly sitting, I don't know about studies about specifically sit, stand, desk, but we say sitting is the new smoking at work, and it is absolutely true. People just need to keep moving, and people will feel like you're not really offering them much if you say, hey, you got to go to physical therapy. But these are people who typically have not, if they've been to physical therapy before, they haven't really engaged in it. They haven't really, physical therapy is about learning the exercises that you then do at home. It's not about what physical therapy does for you for the 1 hour that you're seeing them. And so, again, getting that frame shift to get people to take responsibility for taking care of their own backs and their own back pain and other pains for that matter is really important. And the exercise piece, I can't stress that enough, because exercise has all the other effects. It consolidates sleep. It improves mood as much as a full strength antidepressant. It improves fitness and conditioning. It increases cognition, improves cognition. So people say, I don't want to exercise. It's akin to saying, look, we have this one treatment that does all these magical things, and you're not availing yourself of the single best and most important thing you can do to help yourself. You really don't want to get better, do you?
That's fascinating to hear it that way. We have this one treatment that has all these effects. I'm going to shift my thinking of exercise to be that way. Those were my main questions. I didn't see any others at the moment come through. As always, you'll have my contact information that you can forward along questions, and we can continue the conversation offline. But I wanted to go back quickly to the slides here and just wrap up. Thank you for attending today. We do have a couple upcoming events. This slide is looking a little bit full. And that's great, because that means we have a lot of events, but you can also always click on our Center for Health, Work and Environment calendar here on this link when I send out the slides. But our next webinar is in a couple weeks on February 6th, and it's going to be workplace lactation accommodation. There should be some really great resources from our presenters at both Tri-County Health Department and Boulder County, who are implementing a lot of the workplace lactation accommodation work in both their environments. And I also just wanted to plug the American Heart Association Workplace Health Symposium. That's going to be on Heart Day, February 14th. And so that's going to be at CU South Denver. If you're in the Colorado, Denver metro area, I encourage you to attend for a nice networking and educational event.
I want to just say one last caveat at the end, because we talked about urine toxicology testing. I want to make sure it's clear to people why this is important. Urine toxicology testing is not a chance to catch people and fire them. It is a chance to catch people before you see those behaviors. By the time you're seeing those behaviors of failure at work, people have actually been misusing a drug for quite a while. Those are late behaviors. If you just rely on those behaviors to find the people who are misusing drugs, you're going to miss probably most. In one study of a pain clinic, you miss half the people right off the bat of people with significant use disorders. So the urine toxicology test, again, useful as a surveillance tool, not from a punitive standpoint, but from a how can I help the employee standpoint.
No, thank you for it. That was an excellent addition. All right, well, next steps, if you are interested to learn more about HealthLinks, you can contact us and become a certified healthy workplace, or you can enroll or, because they go one and the same, we have, if you're in Colorado, a Small Safe Well study, which is really looking at the true impact of not only a total worker health leadership training, but the HealthLinks assessment and advising. So help us expand our reach and understanding of what's being done in the workplace, and join the study. And we will see you next time, hopefully on our webinar, and stay connected with us. Have a good one. Thank you. It's really great to have you on.